Good morning, good afternoon, good evening, wherever you are, and welcome to this TechNet webinar. Today, we are happy to welcome Gilles Ries and Jezal Doshi, the founders and managing partners, at Global South Health Ventures, as well as Tahir Puhari, Senior Research Program Manager at Health Africa. And they're here to discuss the deploying of Indigo for zero-dose communities. You can listen to this session in English and French. To do so, please click the globe icon and select the language in which you'd like to listen to this session. And now, please let me say that in French for our francophone audience. Vous pouvez écouter cette session en français. Pour ce faire, cliquez sur l'icône en forme de globe et sélectionnez la langue dans laquelle vous souhaitez écouter cette session. We'd be happy to know who's with us today, so feel free to introduce yourselves in the chat box and tell us your name and where you're from. You can also use the chat box if you need technical support, and I'll be here and will do my best to help you. If you have any questions during the presentation, please use the Q&A box. You will find it at the bottom of your Zoom window. If you don't see the icon, you can click on More and you will find it there. You can ask your questions at any point of the presentation, and our panelists will answer them they will answer them not in writing, but they will answer them after the session during the Q&A session, after the presentation during the Q&A session. Finally, this session is recorded as usually, and we'll share with you next week, or maybe at the end of the week, the links to the videos as well as the slides by email. I hope you'll enjoy this session, and I give the floor to Jessa.
Well, thank you very much, Alex. First of all, I'd like to thank you and the entire TechNet team for organizing this webinar. I'd also like to thank all the participants for what seems to be a very impressive turnout. So thank you for your time and patience and listening to us on what I think is a very pertinent topic. As a quick introduction, perhaps if we can go to the next slide. So before I give my introduction, I wanted to share a statistic. Not many people know this, but the median time it takes for new medical device innovation to hit just 20% coverage in LMICs, so low and middle income countries, is 13 and a half years. And that is the single reason why me and my co-founder, Gilles Ries, started Global South Health Ventures, with a view to helping medical device innovation, medical technologies go to market faster in geographies that need them the most. Because we firmly believe that today public health suffers not really from a high disease burden, but really an access problem. And so what we do is we partner with medical device companies, with multilateral organizations, with ministries of health to help accelerate the go-to-market for medical device innovations around the world, whether it's Africa, South America, South and Southeast Asia. So that's why we started Global South Health Ventures. As a quick background, before this, I was Deputy CEO at B Medical Systems in Luxembourg, a company that many of y'all may be familiar with. It was known earlier as Dometic Medical Systems, and before that as Electrolux Medical Systems. And it's synonymous with blue boxes, SDDs, ILRs. So both me and Jill come from a background of working at B Medical for a long time. And that's the experience we bring of working all around the world in some of the most challenging environments. In addition to that, I also represent Luxembourg as their honorary consul to West India. And so I do work very closely with the government of Luxembourg on multiple initiatives. It gives me great pride to be part of this webinar and present the Indigo in this webinar. With that, I'll just hand it over to Gilles Ries for his introduction.
Gilles, you're on mute, sorry.
Again, a mistake, sorry. So My name is Gilles Ries. I'm located in Luxembourg. For those of you don't know where this is, it's a very small country located in between France, Belgium, and Germany, in the center of Europe. And as Giselle has already mentioned, I've also spent a significant amount of my time working with biomedical systems. My background is more an engineering one and refrigeration, so that's a bit of my data, I can say. So I really put a lot of energy and focus on making sure that, the cold chain we use for vaccination and other applications in the field is really what comes to with expected outcomes. And also proud today to be part of Global South Health Ventures, and as well to be part of this webinar where we present a bit of a new tool which will serve a very specific purpose, as you will see. And with this, I hand over to Tahir.
Thanks, Hales. Okay, so good morning, good afternoon, good evening, wherever you guys are calling in from. My name is Tahir Buhari. I currently serve as Senior Research Program Manager at eHealth Africa. I currently oversee a portfolio of projects, cross-cutting, from digital health, cold chain innovations, and also large-scale implementation research programs. And for the past 10 years, I have been at the forefront of field testing the Indigo vaccine carrier. We have learned so much, from deploying this device in really multiple and varying contexts. And there's so much that we have learned that I'm so excited to share this with you today. And yeah, back to you, Faisal.
Thank you, Tahir. So we'll get to our topic. And I think just to give everyone some context on zero-dose child, who is really a zero-dose child? So if you look at the official definition, any infant who has not received the first dose of DTP1 vaccine by year 1 of age is classified as a zero-dose child. In 2024, there were 14.3 million zero-dose children, which has increased from 12.8 million in 2019, predictably due to the pandemic. In 2020, Gavi had made an ambitious target of reducing the 12.8 million in 2019 by 25% by 2025 and by 50% by 2030. What that means is vaccinating an additional 8 million children, zero-dose children, by the year 2030 every year. Unfortunately, I think we are far from that number. Now, zero-dose children exist and continue for multiple reasons. I think there is a lack of intent to vaccinate by parents. There are issues around vaccination, misconceptions. There are community access issues. A lot of health facilities are not close enough for mothers to take their children to get vaccinated. There are conflict zones, nomadic populations, as well as a lack of outreach programs. For not all of them, but certainly for a large part of them, one of the underlying infrastructure reasons, and I'm sure you're all familiar with this, is the lack of an effective cold chain to make sure that vaccines remain at the right temperature till the very last mile where these zero-dose children are living. And that is precisely the problem that Indigo aims to solve. And with that, I'll just hand it over to Gilles.
And yes, talking about this, we often speak about the last mile challenge. Some also say it's the last kilometer, but I think it doesn't matter if it is a mile or a kilometer. What is very important to understand is that we are not necessarily speaking about a distance, because a mile, as you know, is short, a kilometer is short as well, and can be covered easily. The problem is the time it takes to cover a specific distance. And obviously living in Luxembourg, let's say, where we don't know what traffic jams are, this can be very quick. But there are other regions in the world where this last mile coverage can take very long. I've selected here 3 pictures, as you can see, which are just a short and a small glimpse of what we can see in the terrain, transportation on a canoe, on a motorbike, on a bicycle, on a horse, on a camel. There are a lot of different examples. The problem is comes down to planning. And planning in this case is very often unpredictable because the terrain can change due to meteorological conditions. The population cannot be there due to conflicts. And then the underlying problem is actually the time again. So traditional cold chain equipment like vaccine carriers, for example, which are used for outreach sessions, typically have an autonomy of a day or a day and a half. So if our planning goes beyond that point, obviously the vaccines are in danger and we cannot reach this population. And that's why the last mile is there and why we can also not reach the last mile population, because simply today there is a lack of tools to go that far. Now, when we look at current CCE solutions, as I just mentioned, we have traditional vaccine carriers, which today exist in two versions. Mainly it's a traditional vaccine carrier and then also a freeze-free version, which both are very good if used properly. But again, they depend on ice, which has to be produced at some point. The carrier is then charged with ice, and from the moment on the ice has been conditioned and the carrier is charged, we have a day to a day and a half of autonomy. So you see, this is quite limited. And we all know as well that vaccines, they have to be kept between 2 and 8 degrees to keep their potency. If we go below 2 degrees for a short amount of time, there is a risk of damaging the vaccines through freezing very quickly. And if above 8 or 10 degrees for a defined amount of time, we have heat exposure. And also then again, the potency of the vaccines can be lost. And so therefore, we need to find a tool which really helps us to overcome this 1 to 1.5 days and extend this autonomy to be able to reach the zero-dose population. And that's where we come in with the Indigo and with the next slide. And Giselle, please.
So the Indigo, actually, as a technical solution, was developed by New Horizons, which is an independent entity funded by Mr. Bill Gates. And here you see Mr. Bill Gates talking about several of his innovations. Of course, as you know, and he said this many times, but the work that he's proudest of, with all the money that he has committed and all the philanthropic donations, is his work in vaccines. And I think Indigo is actually a brainchild coming from a problem that he observed about the last mile. So now we get into more technical details about the Indigo and how it actually works.
So the Indigo is also a vaccine carrier, but it is an active carrier. It doesn't depend on ice like a passive vaccine carrier. It is designed as a backpack, so it's quite comfortable to carry around, because it is also designed to be carried around for a longer amount of time. And as we can see here, it is PQS pre-qualified, of course, and it lasts for a minimum of 5 days at 43 degrees ambient temperature. So you can already see that we can extend notably the normal 1-day outreach sessions from a vaccine carrier to 5 days very securely. Now, the Indigo can also be switched on and off. So it is basically a device which is charged. So it has a certain amount of energy contained within the system, which can be switched on. And then after 15 to 20 minutes, it is ready to load vaccines inside. It has reached a temperature profile between 2 and 8 degrees. And once then it is loaded, the outreach session can start, and a minimum of 5 days autonomy is contained within the Indigo. It can be switched on, as I told you, but it can also be switched off. So if a session lasts shorter, maybe only 2 days, vaccines can be transferred again to an ILR. The Indigo can be switched off, and the remaining 3 days of autonomy then, they are saved within the system for a day, for a week, for a year. So this energy is not going to get lost. This device is also freeze-free, naturally freeze-free by the technology it is using. It is also ice-free, so we do not depend on ice provision from freezers. You have also a data download system, so it comes with a logger and included temperature monitoring as well. Now here you can see that, from a previously problem on the last mile with regions which were inaccessible, suddenly they become accessible. So from a fixed storage site, without using traditional carriers, we can reach out for a minimum of 120 hours, multiple sites. This being said, if you use one Indigo for one session, it gives you a limited autonomy of 5 days. But if you decide, for example, that a session would take 10 days, what then is possible is to take two Indigos. So one which is switched on at the beginning of the mission and the other one which is kept off. So after 5 days, if one autonomy has gone down to 0, you switch on your next Indigo and you have another 5 days of autonomy. And this really extends massively the outreach possibilities given by this device. When it comes to technology, that's where it becomes really, really interesting, because I'm sure you have asked yourself, how does this device work if it doesn't use any eyes? So basically, it is using a material which is very known to all of us and used daily, and that's water. In fact, the device uses water as an evaporative media in an inner layer under low pressure. And when the device is switched on, this water starts to evaporate and goes to an outer ring or to an outer layer where a zeolite is contained, and this zeolite absorbs the water. So somehow it works like a traditional fridge, which is using a refrigerant like R134A or R600, but instead of using such a gas, we only use water. Now, this process, once started, can run for 5 days. And after 5 days are over, we have to recharge the Indigo. And this recharging process basically consists of heating the outer layer so that the water, which is now in the outer layer, evaporates and travels back into the inner layer. That's a process which takes around 3.5 hours. And after this time, the Indigo is ready for use again. The Indigo system has been pre-QS pre-qualified in 2024, which is not that long ago, but we have to say as well that it has been used in the terrain already since 2017, something which Tahir will also speak a bit more about later on. It has been used in very different use cases in multi-day outreaches, in reserve logistics, in even replacing it as a stationary CCE in conflict areas where the normal cold chain equipment has disappeared and been stolen. So even there it has served, and in different other campaigns. And this mainly in regions today, which was the Central African Republic, DRC, in Nigeria, in South Sudan, and in Sudan, as well as in Madagascar. So the experience and the exposure of the system to the field has now almost reached 10 years. So it's not a very new technology in that sense, but it has already proven itself in the field with hundreds of deployments. And with this, I'm handing over to Giselle.
So I think Indigo is not a replacement for traditional carriers. It's meant specifically at zero-dose children, accessing children who are not being able to get vaccines today due to infrastructure constraints, due to terrain constraints, and so on. And I think it's very important to make that distinction, because Indigo does not solve every problem, but it is focused on one particular problem. And for that problem, I believe Indigo does a fantastic job. It's, as Jill mentioned, it's PQS approved. It's listed in the CCOP catalog as well, but also for Gavi 6.0. What is also very interesting, as Jill mentioned, is it's almost like a battery bank, which you can power on and off whenever you want. So the 5 days of autonomy, for instance, could be used over 5 months, and you just power it on and it reaches 2 to 8 degrees in 20 minutes. You use it for as long as you want, and you can switch it off, and it retains its cooling power, which actually makes it a very unique device. The autonomy of 5 days is actually, that's as per PQS, WHO standards, but we've tested it, and I'm sure Tahir will talk about it as well. It actually works for significantly longer than that, maintaining always 2 to 8 degrees without any freezing of vaccines, which technically is impossible because it's water. So with that, just going to the next slide, and I'm very excited to hand over to Tahir because he's spent significant amount of time of his life around many different countries in Africa, looking at Indigo, deploying it in real world conditions. Today, we have more than 500 Indigos working all across Africa. But I'll hand it over to Tahir for what I think is a very fascinating study from his real life experiences with Indigo.
Thank you very much, Jaisal. So, for me, over the next few minutes, what I want to share, with everyone on the call is what 8 years of operational evidence has really taught us about how we should be thinking about deploying extended holdover, cold chain technologies, especially in low resource, fragile and conflict settings. Next slide. So before we dive into, what we have learned, I thought it was, important for me to introduce the eHealth Africa group. We are a group of organizations based out of Nigeria. We have eHealth Africa, which is a public health nonprofit organization, which is probably the bigger organization out of all of them, founded in 2010. Then we have eHealth Clinics, which is a public health, a private healthcare provider with about 8 facilities across Nigeria. We also have eHealth Impact Ventures, which is our philanthropic arm, looking to support African innovators and African entrepreneurs. And then we have eHealth Africa Global Health Monitoring, which is a new organization that we acquired last year that is providing temperature monitoring solutions. And then we have eHealth Africa Pharma, which is a pharmaceutical distribution arm of our group. Next slide. So since 2017, we have been working with our partners. I think Jaisal mentioned New Horizons. We've been working with them to evaluate ice-free extended holdover solutions like the Indigo vaccine carrier, both in controlled environments and also, more importantly, in live operational EPI programs. And we have done this primarily by combining WHO PQS style field evaluations and also, looking at quantitative temperature and performance monitoring, and then the most critical, direct qualitative feedback, especially from people that are going to be using this technology, the vaccinators themselves, as to how this device, works to support them. We primarily did this through 2 different types of contexts. One is, field testing this technology in routine immunization programs. And the second one is looking at humanitarian response environments, and especially those environments that are consistently underserved, underreached, for one reason or another, as Jaisal and Giles have, beautifully explained. Next slide. So I think Giles talked about this challenge, that we share across all of the different contexts that we have sort of operated. We know that there is an issue around functional cold chain equipment or lack of, that functional cold chain equipment. But the most important thing for me when it comes to this shared challenge and what we have seen across the different countries that we have worked is this concept of, facilities being tied to ice, the concept of ice leash. This means that if there's no ice, no services are being provided. Vaccinators are tethered to ice availability. And this is one of the key challenges that really hampers our vaccinators to be able to reach, the most difficult areas. So this reliance on ice-based transport, is one of the challenge that is structural in nature and must be addressed if you are to reach more people. What happens is when you combine all of these different challenges, lack of functional equipment, reliance on ice, the long distances, and even the security issues that could potentially happen, what happens is vaccinators are faced with a very, very binary choice. Either you conduct the session, if ICE is available, or you completely suspend services entirely simply because, those daily ICE runs are sometimes, unaffordable, too expensive, or sometimes the ICE is completely even not available. So the consequences of what happens is when you combine all of these is that, there will be a high proportion of zero dose and under-immunized children. You will also see a high proportion of communities that have not been visited, for several months, sometimes even years, simply because, the ICE is not available for the vaccinators to be able to reach, those communities that are quite extremely far. The next slide. So across every context that we worked in, and we've handled deployments in Nigeria, Sudan, South Sudan, Somalia, Ethiopia, there was one pattern that really emerged with remarkable consistency. The success of this Indigo or these types of technologies was really not determined by the hardware. We consistently saw that the Indigo was maintaining safe temperatures. It was giving vaccinators that minimum of 5 days, to be able to operate. But what determines, outcomes was the operational ecosystem that you build around a system like this. You are talking about the charging infrastructure, you're talking about the training, you're talking about, supervision to make sure, things are working as they should. And also you are talking about the workflows or the protocols that you put in place to be able to charge this Indigo and deliver it to facilities for implementation of for routine immunization services or even campaigns for that matter. Next slide. So everything that I'm going to be talking about today, really links to this single central finding. And I would like to do that with a proof of concept using the Borno State case study. So back in 2017, when New Horizons introduced the Indigo vaccine carrier to us, one of the first questions they asked us was, where are the places, where can we field test and evaluate this device? And the first location that came to our mind was Borno State. I think a lot of us on this call may remember, the security situation in northeastern part of Nigeria with the Boko Haram insurgency, with all of the issues that were happening around that area. And we approached Borno State to say, here is Indigo. This is a new technology that is being developed that could potentially give you 5 days of holdover. How can we use it within your EPI system to be able to reach more communities and more children and more people, especially in underserved settings? And Borno State came up with one of the first use cases, and that is leveraging the military medical personnel. As they are out in the field conducting their security operations, they would then use Indigo vaccine carrier to provide routine immunization services as they meet those communities out there. Now, mind you, when the military is going out, they would go out for at least 5 to 10 days every single time. As of 2017, there was not a single technology in the world that would have allowed you to carry vaccines with you and travel for 5 days, not even for 3 days. So this was the first program that benefited from the Indigo. And the left-hand side of my slide, you would notice a map of Borno State. All of the purple areas that you're seeing on this map as of 2017 were either partially accessible or completely inaccessible due to security situation in Borno State. And the military was now in charge of reaching these settlements, during their operations to provide these health services. Indigo was the first device that was used to support the military in doing this activity. And in fact, the military was taking 2 Indigos at a time. So one Indigo will be turned on and vaccines will be put inside the Indigo. And then there will be a second Indigo that, working for 5 days. As the cold life of that Indigo was, finishing, they would then move the remaining vaccines that they may not have used to the second Indigo, further allowing them to keep going on their operations, with viable vaccines that they could be using to provide those services to those communities. So this was one of the first and major lessons, that we've learned, how Indigo can really help teams to extend and go beyond what traditional ICE, would have not been able to achieve. So from 2017 to date, Borno State also looked at supporting other programs, not just, special programs like RIC, which is Reach and Accessible Children, as I mentioned, is being implemented by the military to now look at how can we use this technology to support routine immunization. And I'll be talking about that a little bit. Next slide. So in 2021 was when Borno State wanted to make this pivot from supporting special style campaign programs like RIC to now routine immunization. And what happened was in 2021, Borno State selected some 10 health facilities. And the criteria that Borno State looked at was these are facilities that don't have functional cold chain equipment, but need to provide routine immunization services. So Indigos were deployed for those facilities. And we really saw a remarkable change in terms of how the facilities were delivering their services. Prior to the deployment of the Indigo, they were required to conduct 2 routine immunization sessions per week. And for every single immunization session, the facility has to travel at least 4 times based on what we investigated. If a facility does not have a fridge or does not have a cold chain, they would first of all travel in the morning to what they call Apex facilities in Nigeria. So these are locations that have functional cold chain equipment. Then the facility would collect vaccines and ice, and then they will travel back to their facility. They will implement their session, and then remember, they don't have a cold chain equipment. So if there are vaccines that are remaining in that vaccine carrier, they would have to return, the unopened vials and
Here, can you hear me?
all routine immunizing Indigo. Facilities travel to collect the Indigo and their vaccines. They were traveling only twice because you only travel to go and collect a charged Indigo, you place your vaccines inside, and you come back to your health facility. And the Indigo and the vaccines stay back in your health facility for at least 1 week. And then at the end of the week, you now return that Indigo back either to a charging station or to that place where you had picked up the vaccine carrier. And that was really a fundamental change that I will unpack in my later slides. So we saw a remarkable change in how facilities were reaching children over that 5-year period. In fact, as at end of 2025, Borno State has been able to use Indigo to reach more than 500,000 children, from that time in 2021. Now, I have to qualify that the number of facilities, of course, was scaled year on year as Borno State was learning more about this capability. They were adding the number of health facilities that were using Indigo every single year. Now, I know a lot of people are going to ask me what happened in 2025. I would, point you back to the point that I think Giles made regarding the WHO PQS field evaluation of the Indigo vaccine carrier. It was pre-qualified in 2024. So there was a situation where we had to mop up all previous pre-commercial Indigos from the Borno State ecosystem, which meant that in 2025, we were removing Indigos from the field and replacing them with commercial versions. So that's why you see that major drop between 2024 and 2025. Another major change that we saw from health facilities was the reduction in transportation costs. You compare a facility that is traveling to collect ice 4 times, for 1 session, to a facility that was traveling only twice to collect an Indigo. We saw that there was significant reduction in the transportation cost that is associated with collecting vaccines and coming back to the facility. And by the way, we know that a lot of health workers are actually paying out of pocket to go and collect ice and, vaccines. The other change that we saw from these facilities was that they were now moving away from conducting those 2 sessions per week to daily sessions, right? Because you have Indigo available throughout the week. You are now able to reduce missed opportunities. Any individual or caregiver that shows up in your health facility, you are able to provide vaccination services without having to tell them to come back on Monday when we have our fixed session, or come back on Thursday when we have our outreach session. So that was also one of the major shifts that we saw from these facilities. Next slide. So there were so many lessons that we have learned, but of course, with any medical or cold chain technology, the first thing that you look at is to evaluate its technical performance. And of course, that is absolutely necessary, right? The technical performance of the Indigo was established over all of the different locations that we supported this deployment. But we did see performance variations, locations where Indigo, was really providing great services, was working really well, and locations where we saw a lot of temperature deviations and issues. And what we saw in high performance sites was that there was adequate training. The facilities were also familiar, with the Indigo system in terms of how it is used within the RI program. There were clear workflows in terms of how Indigo should be charged, when it should be deployed, the time it takes to charge, deploy, and then return used Indigos back to your charging station. And we also saw that regular supervision was something that was also really critical if this device is really going to succeed or do what it was designed to do. And with sites that had deviations, of course, we saw either one or two of these factors really missing from that. So the takeaway for this lesson is really simple, but very important. Of course, the baseline technical performance is confirmed. Implementation quality now becomes the dominant determinant of outcomes and the success of the system itself. Next slide. So after deployment, the human factor also has a great influence. In high turnover environments where health workers are being moved quite frequently, and we see this a lot, staff rotation when it comes to EPI programs is also something that is quite, common. When a trained personnel leaves, the institutional knowledge of how to use that system also leaves with them. So the most common issue is where we also see this, staff retention, affecting the knowledge of how to use the device. We also saw some interesting issues around interpretation of the temperature indicator. Remember, on the lid of the Indigo, one of the key information that is there is the holdover. So we sometimes find, health workers struggling to understand, what does holdover mean? If I see 3 days of holdover remain, does it mean I have used my Indigo for 3 days, or does it mean I have 3 more days, to use this Indigo? So we saw that there was a real factor that we needed to explain this information to healthcare workers for them to understand how they can use it on their day-to-day work. The second issue I think that is important is mistimed or delayed charging. With any Indigo system, the charging is really, really critical. You want to have a very efficient charging cycle where Indigos are charged, deployed, used for 5 days, and then used Indigos are now returned back to the charging station. So you want to have a very efficient cycle where no Indigo is staying out in the field when it is not charged and not being used, because by default, that means you're losing capacity of the system. Next slide. The third lesson, which I think is also really critical for scaling, is that the binding constraint at scale is the charging ecosystem, not the vaccine carrier itself. And this lesson consistently surprises a lot of us, especially when we are thinking about how should we design the Indigo system for our EPI program. The Indigo vaccine carrier is not the bottleneck itself. The charging infrastructure in our deployments, it was the recurring constraint. So dependence on generators, because obviously for charging, you will need access to reliable power, unpredictable fuel availability. In Borno State, there were certain regions that, fuel availability was quite difficult. Limited personnel training to manage the charging itself, because the charging also has to, be managed by somebody. And then underestimating the distances between the charging facility and the implementation locations. So how far are you placing this charging station against the vaccinators or the facilities that will be using this technology? So we saw that where charging logistics had been planned carefully, responsibilities were assigned, backup plans in place, the performance of the system really was quite reliable, and we saw that in Borno State. But where charging is an afterthought, the utilization of that system, we saw that, quite obviously declined. So if you are planning for Indigo deployment, it's going to be very, very critical that you map the charging ecosystem for every facility, and you need to start there because that's what determines, the scale of your system. Next slide. So the fourth lesson, I think I talked about this briefly, is that extended holdover doesn't just, transport vaccines. We saw that it was transforming planning. And this is perhaps the most powerful lesson that we have learned. Before this technology, every immunization session was constrained by how far you could travel and still return before the ice has melted. Sessions were actually planned around the ice, which is why we had this protocol of facilities conducting 2 sessions per week. But when you have multi-day cold life, that logic completely reverses. We observed facilities were conducting more sessions. We saw teams conducting multi-day outreach, going into the communities and actually staying in the communities, and then moving on, to further to reach even more communities that are hard to reach. So we saw that facilities were able to change their planning behavior, right? How did they do this? They changed the number of sessions that they were providing. They reduced missed opportunities. They also had the opportunity to potentially even reopen facilities that were previously closed. And we saw this in Borno State, in Abadam and Marte local government areas, where the state completely made a decision not to invest in cold chain infrastructure due to the insurgency. But they felt like Indigo is a portable device that will allow their vaccination teams to quote unquote hit and run. That was also another intervention that Border State, came up with. So really the bottom line is the technology functions as, not only a transportation device, but as a planning enabler. And this is very important for EPI programs to think about how extended holdover devices can help us to rethink the strategy that we have when it comes to routine immunization service delivery, especially for fragile, low resource and perhaps even conflict affected settings. Next slide. So in terms of the persistent limitations that we have seen, over the 8 years, I think dependence on the power for charging is one of those major ones. You're really going to have to do a good job of understanding, what is the power availability for all of the charging stations that you're considering. Then the second one is maintenance, and I think maintenance should not be underestimated. Maintenance is really, really important and very critical. When it comes to the Indigo vaccine carrier itself, I think it's intentionally designed for low maintenance. But when it comes to the charger, for example, that is another story, right? Because the charger has a lot more components, with boards, sensors, and all of that. So ensuring that there's local capacity to maintain those devices is also something that is really critical and would affect your success. High turnover in training, this is also something that I mentioned earlier, making sure that there's refresher trainings for health workers, understanding the information that is on the lid of the carrier itself, how to charge, deployment protocols, all of those things are really, really important. And then the last one, the Indigo, of course, is not cheap. So there are upfront system costs that will require institutional financing, for example, setting up the charging facility and making sure that that is structured in a very good way. So that is also something that would most likely affect the success of any Indigo program. Next slide. So I'm trying to summarize what 8 years of the evidence can support us saying and what it does not support us saying. So we can say with confidence that extended holdover solutions do reliably perform under real conditions. Human system factors matter more than device capability. And that multi-day cold life really has the capability to expand immunization programs' reach, especially in low resource settings. But we cannot sit here and claim automatic coverage increases to the device alone, or even assumptions that scale is achievable without serious investment. So these are what we can reliably say. Deploying this device with intention is the most important thing. You need to think about the human, the operational, and the infrastructure ecosystem that is needed to build this system to do what it was designed to do. Next slide. So I think I wanted to end with this slide in terms of what it means for policy, for scaling up decision based on the evidence. We would recommend 5 considerations in how to advance these types of technologies. One is when it comes to evaluation, we should not be evaluating devices as standalone infrastructure. We need to evaluate devices as component of a larger and broader ecosystem. Then the second one is when it comes to planning and budgeting for these types of technologies, it is important to also think about the other infrastructure, the training, the capacity building that is needed in order to make sure that this system is designed for efficiency. And the third one is, of course, you need to expect, learning curves. Like any technology, people would need time to understand how it works and how it can be modified and tailored to their context. And then maybe finally ensuring that sustainability is integrating these type of systems into existing programs. If you're going to place a charging station anywhere within your EPI program, I would not recommend you set up a completely new facility. Can you set up this charging station in an LGA cold store or a state cold store where there are already infrastructure for power provided? Can you place charging stations within vaccine resupply routes? How can you embed this system into existing structures of the EPI program without adding additional structures? So these are some of the key recommendations that we wanted to make, for any EPI program that is considering the Indigo as a device, to extend their reach. So we're happy to go deeper on any of this during the Q&A. The Nigeria context, of course, gives us a lot of lessons, and we'll see what that looks like. Back to you, Jaisal.
Thank you very much, Tahir. Very interesting. I think I'll hand it back to Alex, and we can open up for some Q&A.
Thank you. I think Gilles is going to manage the Q&A. So Gilles, the floor is yours.
Yes, so also maybe to already wrap up a bit, there has been a lot of questions which are around charging, or charging means, and B, around price and costing. When it comes to charging, it is true that obviously somewhere we need to get the energy from, and that's today it's electrical energy. And this electrical energy is needed to heat the Indigo carrier in some kind of an oven. You can imagine an oven with a fan to regenerate it. This oven is using around 3.5 hours to recharge the Indigo, and around 2 kilowatt hours of energy for a charging process. Today, what is needed is AC power, so from the grid. So obviously it works ideally to charge the Indigo when you can do this in a place where grid power is available. It can, of course, be powered as well by a generator, but we all know that generators are not ideal in the cold chain environment, and it's not the preferred solution. So what we are currently working on with the manufacturer, who, by the way, is a company called EMK, and it's a company which is set up in east of Germany near Leipzig, is the development of a solar array to charge the Indigo. Of course, you can already use a solar installation in a health center if that provides enough power simply by plugging it into these ACs. But what we plan to do is having more or less solar direct drive system to charge the Indigo. This will be ready in a not too long time, so everyone will be able to benefit from that as well. I'm also, maybe I let Jaisal explain a bit around the price and costing questions.
Sure, Jill. Thank you. So I think because, as Jill, you mentioned, there have been multiple questions about the price. So the Indigo, the PQS catalog price is about $2,000 and a charger costs about $3,000. The recommended ratio is for every charger, you can use between 5 to 10 Indigos. So, of course, this is a significant investment for countries that are considering to use the Indigo. However, as Tahir mentioned, I spoke about it earlier as well, the Indigo solves a very specific problem of creating access where none exists today. And therefore, when we look at the implications and when we work with partners, we also look at what are the impact in terms of vaccination numbers, in terms of immunizing zero-dose children, as well as, of course, the savings that you have, as Tahir mentioned already in his slides, in terms of reduced travel time and so on. But yes, I think one of the key constraints to Indigo's widespread adoption is its high cost. It is a function of the technology and the manufacturing process. So we are working on seeing how we could reduce the cost. That would be in the next generation, but I think it's not going to come anytime soon.
Thank you, Jezal. So I'm just reading a bit through the questions. Christoph is asking, what is the temperature necessary to regenerate the system? We talk about around 300 degrees Celsius in the oven. But there is also a fan, and this fan is cooling the inside of the cabinet to make sure that the water, which is going back to the inner layer, is effectively condensing. So it's not enough to just massively heat it from outside. That would not work. We do have Guy Watson. I know the Indigo from its first showing at the TechNet. What have you seen as the biggest hurdle taking a product like this from innovation, operating pilot to implementation? Well, Guy, in fact, so we have come in last year with New Horizons, so quite late on the development. But I guess that maybe the best place here to give a little bit of an answer would be here.
Yes, I think that's the question on whether would it be accurate to say that the involvement of the military in the last mile played a more critical role in reaching zero-dose children than the technology itself. I just love this question. So for me, I think the involvement of the military in last mile delivery, of course, is quite an important and critical enabler, particularly in those, security constrained environments. However, I would not position this as military versus technology, right? The military addressed access and mobility constraints. The technology addressed temperature integrity, reliability, and making sure that as they are out there in the field, that they have a carrier that would allow them to carry vaccines for that period of time. So I would characterize it, as that. It's the combination of what the military did when it comes to access and mobility constraints, and what the technology will allow, the military to be able to do that. And as at 2017, mind you, there was not a single vaccine carrier in the world that would have allowed the military to be able to do this. They would have had to carry 5 days worth of ice, maybe in the trunk. And I think they might have to give up bullets for ice in that situation if you have to debate those.
Thank you, Tahir. So, Guy, to come back to your question, I think this we try to answer it separately, and we get in touch with some of the former New Horizons guys. Maybe they will be able to help us on that, or if some of them is on the meeting here, they could place an answer to that question. Then I see Haptamu, we have deployed the Indigo in Reach Ethiopia. However, the main challenge is the expensive price for specific charger, which is near to an STD refrigerator. But yes, the charger is expensive. It's a $3,000 device, but you also need to remind that it's not one Indigo that is using one charger. it's a system. So mainly you have one charger centrally placed, which can then serve up to 10 Indigos, right? Because you can do different outreaches from that central point. And that's why also when doing this calculation, you have to split the cost of the charger onto the diverse Indigo carriers that you are going to use. So again, it's not one charger, one Indigo, but one charger for up to 10 Indigos. Then we have Fatima. Thanks for answering the questions. I'm especially interested in Indigo because in South Sudan, we are implementing a zero-dose mobile vaccination project, and we are currently procuring Indigo devices, but there's still limited local experience. So we are keen to learn from others who have used them in similar contexts. But Fatima, I think, again, here the best place to speak about used context is really Tahir at this point in time. So Tahir, if you have a bit of an answer to that question.
Yes, and actually I was in South Sudan. We had a collaboration with IRC. We did visit South Sudan to support them in brainstorming what Indigo deployments could look like. So we're always happy, of course, to engage. Fatima, I'm happy to share my contact information. You can reach out to me and then we'll help you think about that. Giles, I think there was another question from Andrew on the call, and he was wondering whether we can characterize 2025 as sort of an early indicator of transitioning the Indigo device to routine immunization. So I would agree very much that, yes, we need to start thinking about how this system can support, beyond, your emergency or campaign style settings, and integrating it into national cold chain inventories. One of the really, really interesting decisions that Borno State took, and I briefly mentioned this in my presentation, is they looked at two particular local governments on the northern part of the state and said, we are not going to buy expensive solar devices to install in that place because the intensity of the insurgency in those locations was high. That infrastructure was either going to be destroyed or stolen. So they said, no, we're not investing in fridges for this region. Indigo is a portable, transportable device with reliable time. We should be able to use it to access these communities and come out. And they call that, quote unquote, the hit and run model. So I think we need to start thinking about beyond emergency context, how can we institutionalize this for EPI programs to extend that capability for these types of use cases?
Thank you, Tahir. I think also it's important again to mention that so the Indigo is not a device which is intended to replace all the vaccine carriers which exist in the system. By far not, right? Therefore, it is far too expensive. But it is a special tool which serves a special need. The special need is this 10 to 20% zero-dose children, which we still see in all the African countries. And to make sure that they can get vaccinated, this specific tool has been developed. So let's also not look only at it as a very high cost device, but let's look at it as a tool which helps us to, get these children also vaccinated and immunized. I think that's really the purpose, and that's also how we have to see it. It's really not this device which is going to replace the 10,000 carriers in your countries. The carriers, they remain there and they still are good for 80 to 90% of the sessions. So it's a tool which helps to serve a purpose, and that's really how we have to look at it.
Giles, I love this point that you're making, because a lot of the times when we're talking to EPI programs, they see this from the perspective of, should I be thinking about replacing my carriers for campaign with Indigos, or should I be? And I think that is a really, really critical point for people to understand. The way that EPA programs should be looking at these types of technologies is really to use the capability to tailor the interventions. Where are the cases or the use cases where Indigo lends itself very, very well, to reach more people? That's where Indigo belongs. There's a place for ICE as well. In urban areas where you have reliable power, reliable cold chain infrastructure, I wouldn't say you should invest to put Indigos in those types of contexts. So really it's for EPI programs to really think about specific technologies, specific capabilities for specific use cases, and to see it as a broader sort of strategy of the tools or the different types of tools that those programs would need to be able to be effective and reach the most people.
Absolutely. Thank you very much, Tahir. So I do not see any other open questions. If someone still would like to ask a question, we are still here. But this being said, also I see the time of the meeting has elapsed. So Alex, are we going to close? Are we going to share contacts?
Yes, thank you, Gilles. So thank you very much for a very interesting presentation. We're going to share all the information, so the slides as well as the recordings by email. And I will speak with Gilles, Jezal, and Tahir to see what other type of information we can join in this email, such as email contact. In any case, I would like to thank everyone, so the presenters and the participants, for a very interesting presentation and conversation. And yeah, I'm looking forward to the next TechNet meeting, and we'll be in touch. Thank you so much. Gilles, Tahir, Jezal, would you like to say a last word?
I'd just like to thank all the participants. I think it's been a very interesting discussion and also a lot of insightful Q&A. So thank you, everyone, and I hope this was useful to everyone.
Yeah,
Tahir?
thank you everyone for your time. I really appreciate this. Please do reach out to us. We're always happy to explore and engage with you. There's so many different ways this technology can help and support EPI programs. So we want to hear all of the questions, the good, the bad, the ugly. Please reach out and we're happy to support. Bye.
Yeah, thank you also from my side. And as Tahir mentioned, so please do not hesitate. We will make sure you can reach out to all of us, and we are very happy to discuss. And we're also very happy for critical questions and constructive questions that help the entire system to benefit from it. So thanks a lot to all of you, and have a wonderful rest of the day and week.
Thank you so much. Bye-bye.
Bye.
Bye.